Good morning, welcome to the next session. And this free paper session has got certain rules. Please stick to the timings. That the first rule, that you must stick to the time. It is 5 minutes. And any extra time you take, marks will be deducted accordingly. For half a mark, for half a minute. Can I request this first speaker? कहाँ है?
Dr. Sabyasachi? Yeah, he is there.
Good morning, respected dignitaries. Our free paper is titled Post Hoc Analysis of RCT on Injection versus Sponge-Based MMC Augmentation in Phacotrabeculectomy, and we have no financial disclosures. Glaucoma surgical trials today typically divide recruited participants into a number of groups, depending upon the type of interventions they receive. Thereafter, the apparent success or failure of the study intervention is determined by a time to event analysis, such as a Kaplan-Meier survival or Cox's proportional hazards. However, one must remember that this time to event analysis utilizes a life to death model, and several of censoring criteria such as IOP above or below a given cutoff cannot be akin to death because they may be altered post-operatively through additional interventions which are minor and anti-glaucoma medications. Herein lies the fallacy of results obtained through glaucoma surgical trials today, where participants are right censored permanently whenever this IOP threshold is breached, giving rise to a variable loss of information which might otherwise have given rise to slightly different outcomes. An alternative to this could be a multi-state model, but it is not commonly used in clinical practice because of the complexities involved. A midway path could be to identify an appropriate submodel from the complete model and perform an analysis on this, and this analysis would be equally easy and accurate. The aim of the study was exactly this, to apply this sort of a multi-state model approach on published RCT data to understand the true influence of different covariates on IOP control in MMC augmented phacotrabeculectomy. Methods. In the original study, there were two groups. One group received sponge-based MMC augmentation, and the other group received subconjunctival injections. There were 62 eligible participants in each arm. We performed a semi-parametric modeling on the published dataset. Our test covariates were age, gender, MMC augmentation type, and glaucoma medication intensity index calculated using Wong formula. A p-value less than 0.05 was used as the threshold to reject the null hypothesis. Results. For model simplification, in the first step, we eliminated the state repeat surgery because none of the participants underwent the same in the published dataset. We also realized that transitions from surgery to any other subsequent step on the first post-operative day was likely to be related to intraoperative factors, and therefore we eliminated that state as well. In the intervening model, we noted that the number of transitions between hypotony and target IOP were too low to perform a meaningful covariate-based modeling. Therefore, our final model was a bidirectional two-state model. A forest plot summary for crude and adjusted hazards for transition between IOP within target range to IOP above target range revealed that glaucoma medication intensity index was the sole predictor which increased the risk of this transition. In the reverse direction, in the adjusted model, sponge-based MMC augmentation and male gender reduced the risk of transition. Discussions. We found that the multi-state model reduced data exclusion from 39.19% in the alive death model to 6.72% and was more specific. Prolongation of anti-glaucoma medication use preoperatively increased the risk of high IOP postoperatively. This was probably related to chronic conjunctival inflammation and Schlemm's canal remodeling. Male gender and sponge-based MMC reduced the likelihood that IOP above target levels would recede to IOP within target zones. This was possibly related to increased risk of bleb encapsulation in males and hypofunctional blebs with sponge-based augmentation. What had been reported was that the route of MMC administration was the sole predictor which influenced phacotrab success. With this post-hoc analysis, we found that the multi-state model provided more information, and we noted that the preoperative anti-glaucoma medication was the sole predictor for loss of IOP control, while the mode of MMC augmentation merely influenced the ability of the filtration system to regain IOP control. The limitations of this post-hoc analysis was that statistical power could not be assessed, and there was asynchronous updating of the glaucoma medication intensity index, resulting in unmeasurable error in assessing the effect size. Thank you.
Can you, I know your analysis was extensive, but can you tell that between the two, which had the bleb morphology was better in which, and the longevity of which bleb was better?
Madam, we did a post-hoc analysis. So in the published data set, we did not have any bleb morphology reported. So that is why I had put that question mark, because it is our assumption that the bleb morphology would have been poorer in the sponge-based group due to unfavorable pharmacokinetics.
Yeah, actually there are too many factors in a trabeculectomy to succeed or not to. So I think it is a very simplified version. But anyway, it's a good thought process. Thank you.
Thank you, sir.
Thank you, Dr. Sabyasachi. We have our next speaker ready. Dr. Vanitha, please.
Very good morning to one and all. Slides are not moving. Yeah. So minimally invasive glaucoma surgery are newer surgical devices as well as procedures that are usually blebless and with small incisions, and can be categorized in several ways. Broadly, these can be ones that reduce aqueous production or inflow MIGS, and those that promote drainage, which is outflow MIGS. Whatever the MIGS, generally they utilize natural physiological pathways, as you can see here: trabecular meshwork, ciliary process, and suprachoroidal route. Where the outflow MIGS are concerned, it is said that they open up dormant collector channels, but this is limited by the episcleral venous pressure, and so it is said that very low IOP cannot be achieved, and it is effective only in early disease. So I set about to investigate the safety and efficacy of combining two types of MIGS, inflow as well as outflow, in advanced primary glaucomas, and compare it with the current gold standard of phacotrabeculectomy. Of course, phaco surgery was performed with it. Retrospective study of advanced glaucomas, primary glaucomas, who underwent combined MIGS procedure or trabeculectomy with mitomycin C along with phaco. Primary outcome measure was IOP greater than 5, less than 15, less than equal to. Secondary were anti-glaucoma medication, total success, complications, and interventions for these. The surgical steps of combined MIGS all were done under subtenon's anesthesia. Initial KDB was done after patient and microscope positioning. Then phaco was completed, and once IOL was in the bag, then endoscope was introduced into the sulcus, and ECP was done for about 210, maximum 210 degrees. And at the end of the procedure, it was very important to give dexamethasone subtenons. Surgical steps, mitomycin C was injected in all my cases. They were then shifted to the OR, mostly were done topical under sterile conditions, and they were separate side, both superior. First, a rectangular flap was raised, and then clear corneal phaco was done at an adjacent position next to it. Then the trab was completed with 10-0 nylon into 2 to the sclera and 10-0 vicryl to the conch. Where preoperative characteristics were concerned, the two groups were not very different. Combined phaco-MIGS had 34 patients and phaco-trab 37. Pre-op medications not different, and also the severity of glaucoma. What was different was slight increased IOP in the phaco-trab group and slightly better vision in the combined phaco group, combined MIGS group. Where both the groups were concerned, they were both effective in reducing intraocular pressure, number of anti-glaucoma medication, as well as improvement in vision. When the two groups were compared together, the final IOP was much better in the combined MIGS group, but this was not statistically significant. and neither was the final anti-glaucoma medication. However, where visual acuity was concerned, it was much better, statistically significantly better in the combined phaco-mix group. Between groups, again, when complete success was concerned, that was not very different, but total success was better in the combined mix group. Failure was more in the phaco-trab group. So was the serious complications defined as sight-threatening complications as well as visual acuity worse by 2 or more lines, and interventions also much more in the phaco-trab group. So, combination of inflow and outflow MIGS seems to have an additive, synergistic effect which a single MIGS may not be able to achieve. And this is akin to the combination of anti-glaucoma medications that we use all the time. It can achieve a low target IOP in a very safe manner. And the role of episcleral venous pressure, including that of the collector channels in advanced glaucomas, is still unclear. I would conclude that combined inflow-outflow MIGS along with phacosurgery is in the least non-inferior to the current gold standard in advanced primary glaucomas. It is not only much safer, but it has better preservation of vision and avoids all bleb-related issues with lesser number of post-operative interventions. Of course, larger studies and longer follow-up is recommended. Thank you.
Thank you, Dr. Vanita. But how much sure you are that you are doing it with a mix and without mix? So even without mix, if it, phaco intraocular pressure comes down to a significant level sometimes.
Not POAT, sir.
So once you put the mix, and how do you really individually decide that how much pressure is coming down with the mix, additional pressure?
I have not put any device, sir. I have used goniectomy as my mix procedure, along which is the outflow procedure, and ECP as my inflow procedure. And I have studied, and of course not part of this study, studied MIGS standalone versus MIGS with, phaco-mix and, phaco-mix and phaco. And I have found that we reduce the IOP by half in phaco-mix and that of medication by half.
Thank you.
Normally, MIGS is performed in mild to moderate disease, right?
I
So
addressed
what
that issue, sir.
what made you think that it will act equally effective in advanced cases?
So we are utilizing two channels here. We are utilizing not only reduction in aqueous production, but we are also enhancing outflow. So physiologically, that makes sense that if we are doing both together, then it might just work.
Yeah, but if the IOP goes too low, and in these very advanced glaucoma where you could actually cannot tolerate hypotony at all, so
Hypertony was not seen in any of the cases. Never.
Thank you, ma'am. So we have our next speaker ready, Dr. Arnav Panigre.
So the role of minimally invasive glaucoma surgery in advanced glaucoma. I am Dr. Arnav, and I'll be speaking on a comparative evaluation of gonioscopy-assisted transluminal trabeculotomy compared to trabeculectomy in advanced pigmentary glaucoma. As we know, pigment dispersion syndrome is caused by episodic release of pigments which go and clog the trabecular meshwork. Hence, it seems feasible if we remove the resistance which has been created at the site of the trabecular meshwork, the IOP control would be fine. And that's what we aim to achieve here. Since trabeculectomy was till now the go-to surgery in cases of pigmentary glaucoma, we wanted to establish a safer alternative which can achieve a similar IOP control. Hence, we wanted to evaluate the safety and efficacy of gonioscopy-assisted transluminal trabeculotomy in advanced pigmentary glaucoma and compare its safety and efficacy outcomes with the standard trabeculectomy in patients of similar severity. So this was a prospective randomized study conducted at AIMS RP Center. Consecutive patients of advanced pigmentary glaucoma who were uncontrolled on medical therapy and warranted a surgical intervention were recruited for this study. The patients were randomized using a computer-generated table into either of the two groups to receive either a GAT or a trabeculectomy with 0.02% mitomycin. Advanced glaucoma was defined as per the Hodaya-Parrish-Anderson criteria with a threshold set at minus 12 decibel mean deviation. Other causes of pigment dispersion like trauma, uveitis, angle closure, and pseudoexfoliation were ruled out. So for the outcome measures, we decided to follow the WGA consensus for reporting glaucoma trials where two different criteria were established. For criteria A, it warranted the use of an upper limit of IOP and a minimum reduction from baseline values. So these were set at 18 millimeter of mercury and at least a 30% reduction from preoperative values or a reduction in number of medication was considered as success. For criterion B, we decided to separate into two groups depending on severity of glaucoma. For mean deviation between minus 12 and minus 24 decibels, the upper limit was set as 15 millimeter of mercury, and for those who had a mean deviation worse than 24 decibel, upper limit of 12 millimeter of mercury was set. Please note that there was no criteria for a percentage reduction or a number of medication using criteria B. So ability to fulfill these criteria without any glaucoma medication was considered absolute success, and the need for glaucoma medications for control of the same was considered as qualified success. So at the end of 1 year, we noted that the post-operative IOP was similar in both the groups, and both the groups displayed a similar IOP reduction. This was achieved with the help of 0.7 and 0.5 medications and GAT and TRAB group respectively. It is of interest to know that 6 eyes had a VFI of less than 10% and a mean deviation of less than 30 decibel, which meant these patients had very advanced glaucoma. And all of them were controlled with GAT, with only 3 of them needing medication. On contrary, this count for similar severity in trabeculectomy was 1, and the patient was controlled off medication. So the qualified success was 100% in both the groups. The absolute success was 60 and 67% by criteria A and 50 and 58.3% by criteria B. Hyphema was seen in 80% of the eyes in the GAD group. All of them resolved on conservative management by the end of 2 weeks. One patient had a late IOP spike which wanted medical therapy. 2 patients had hypotony post-trabeculectomy, which persisted beyond 3 months of age. However, the hypotony was self-limiting and it came back to normal values at the end of 6 months. No eyes in the GAD group had any sight-threatening complication. This is another interesting picture of the same patient. This left side panel is of the inferior angle and the right side panel is of the superior angle. What we can see on the right side is a well-defined trabecular cleft, which was also elucidated on AIOS2025. On the left panel, we can see there is a reduction in the amount of pigmentation, which we can see with a clear white color band appearing in the middle of the trabecular meshwork. To conclude, GAT is an effective procedure for advanced trabeculectomy for advanced pigmentary glaucoma and can be attempted as the initial surgery of choice in pigmentary glaucoma, with the understanding that medications may be needed to achieve some further control. Thank you.
Thank you, Dr. Panigdai. But there are a few unanswered questions. The thing is, why did you choose 2 groups of the same surgery, the same type of patients in 2 groups? Because you are not doing anything to the trabecular meshwork where the pigment is deposited in a great degree. So if you do a curettage procedure and compare with another procedure, that would be more worthwhile. Why did you choose GAT and trabeculectomy in the same type of eyes?
So
because that is actually you are not touching the trabecular meshwork,
yes,
and
sir.
which is filled with or with trapped with pigment.
So, as of now, GAT is a recently emerging trend with more and more surgeons getting the hang of it. Since it has been described, most of the GAT surgeries has been described in primary open angle glaucoma. Some studies have included PCG. I went back, reviewed the literature because it seemed very logical to just treat the trabecular meshwork for treatment of pigmented glaucoma. What I noted was there was no study which evaluated the outcome of GAT in pigmented glaucoma. There were only a few reports which were a part of larger study groups which was widely heterogeneous, like they included pseudo exfoliation, JOAG, POAG. Hence, and since trabeculectomy is the current standard of care in any form of advanced glaucoma, so we wanted to see if the logical thing would lead to a similar IOP reduction.
Okay, thank you.
Thank you. Yeah. Is Dr. Meghana ready? So judges, please note she is not ratified and hence not eligible for any award.
I think the next speaker should come on
Yeah.
stage while the previous one
Dr.
is talking.
Madhavi, please.
Good morning to all. I'm going to present outcome of bent ab intraneedle goniotomy versus conservative treatment for controlling intraocular pressure in primary open-angle glaucoma patients. Introduction. Early intervention is necessary in visually debilitating diseases like glaucoma. Newer treatments like MIX use smaller incisions with less tissue manipulation. Mixed treatment saves conjunctiva, reduces complications like bleb infection and hypotony. Bent ab intraneedle goniotomy is cost-effective, quick, and allows rapid recovery. Minimal literature exists on newer modalities, so this study explores the efficacy of standalone bank in reducing intraocular pressure, decreasing anti-glaucoma medication usage, studying the complications and patient quality of life over time. The goal is to provide the valuable insights for further treatments. Methods. The study was conducted at the institute over 1 year, 4 months. It was a prospective, randomized, controlled, comparative analytical study where 46 patients with mild moderate glaucoma were included. The patients were diagnosed clinically, structurally, and functionally and divided into 2 groups. Group A underwent surgery, whereas Group B was conservative treatment with anti-glaucoma medications. The statistical analysis included descriptive statistics and test for associations and comparisons between the groups. The p-value less than 0.05 was considered significant. Results. A standalone bank study shows that mean IOP at 3 months decreased from 15.22 at baseline to 13.48 with the error of 2.78 mm of mercury on 0.26 plus or minus 0.55 topical anti-glaucoma medications at 3 months. The percentage reduction was 11.2%, though the percentage reduction was 11.2, but all the patients had IOP less than 21 mm of mercury. Thus, our study was successful in reducing both IOP and number of AGMs significantly with improvement in quality of life in surgical group compared to medical group, proving bank to be efficacious in controlling IOP in mild to moderate glaucoma. Discussion. Intraocular pressure, Group A, where 23 patients underwent surgery. On post-operative day 1, the IOP decreased to mean of 12.52 of anti-glaucoma medications. On 1 month, the mean IOP was 15.74, however, which was slightly higher than baseline. On 3 months, the mean IOP was 13.48 with mean AGM 0.26. The patients were on 4 patients were on 1 AGMs, whereas 1 patient was on 2 AGMs. Thus, there was significant reduction of IOP. Group B, there was no significant change in IOP at final follow-up. Intra-group comparisons, the 2 groups varied in terms of IOP on post-operative day 1 and 1 week. Thus, 18 patients had complete success and 5 patients had qualified success and no failure was noticed. Medication dependency. In Group A, the mean number of AGMs decreased from a maximum of 2.74 at the baseline to a minimum of 0.26 at the final follow-up. This change was statistically significant in reducing the side effects of AGM. Thus, in helping in reducing the number of AGMs in Group A was beneficial to patients in long-term basis. In Group B, the mean number of AGM increased from a minimum of 2.22 at the baseline to a maximum of 2.91 at the follow-up. This change was also statistically significant. Quality of life, it was assessed through NEI VFQ25 questionnaire at the baseline and the final follow-up. In Group A, the mean visual questionnaire score decreased from a maximum of 92.83 at the baseline to minimum of 16.74. The quality of life improved and all patients were satisfied with the surgery. In Group B, the mean questionnaire increased from minimum of 83.58 at baseline to a maximum of 98.26 at the final follow-up, proving the patients were not satisfied with the AGM due to its side effects, and this change was also statistically significant. Intergroup, the quality of life was best in Group A than in Group B. Complications in Group A, raised IOP, 3 patients noticed raised IOP at 1 month, which was attributed to inflammation within the trabecular meshwork, and they were steroid responsive. However, the IOP was less than 21 mm mercury at 3 months, and the inflammation subsided with the usage of steroids was also tapered and stopped. IFEMA was seen in 10 patients, and which was transient in nature and subsided within a week through head and elevation, post-operatively, and usage of topical steroids. Inflammation, AC reaction in the form of AC cells ranging from 0.5 to 1 plus was seen initially in 5 patients and reduced to 0, which was managed with topical steroids. Iris atrophy was seen in 1 patient. Overall, the number of complications decreased from maximum of 0.87 at POD1 to minimum of 0.17 at 3 months.
Your time is up, Dr. Meghna. Can you just go to the last slide and just give us the conclusion?
Thus, to conclude, BANG is a promising option for mix for mild to moderate glaucoma, and it reduces the reliance on anti-glaucoma medications and complications, thus preserving the conjunctiva for further traditional procedures like trabeculectomy if necessary. Thank you.
Thank you. Judges, do we ask questions or do we move ahead?
Any questions?
How did you differentiate between steroid response and IOP spike? Because IOP spike is noted after these surgeries sometimes.
Ma'am, we had taken the baseline IOP and we had seen, but that was a confounding factor.
Thank you.
No, you have chosen only moderate and severe glaucomas and
No, sir, only mild and moderate glaucoma.
mild and moderate glaucomas, all open angle.
Yes, sir.
And in open angle, you did a bang.
Yes, sir.
What was the rationale?
Sir, we had
If
to,
it is a closed angle, you do the bang, it's okay.
sir, we wanted to try an open angle also because bang was less, it was safer and it was cost effective. So we proved that even in primary open angle, bang is efficacious. And all the studies were on closed angle. There was no study comparing with open angle. So we wanted to try bang in open angle as well as.
How do you explain that the pressure has reduced because you did in the open angle, bang in the open angle? How do you explain? How do you explain then that the pressure has reduced even in open angle glaucoma if you do a bang?
I'll go.
Okay, thank you.
Thank you, Dr. Madhavi.
Good morning all. Today I'll be discussing our free paper on outcomes of bleb needling with high dose, that is 40 microgram injectable subconjunctival mitomycin in failing or flail blebs. As we all know, trabeculectomy in the age of antifibrotic agents has become much successful. However, the bleb is known to remodel indefinitely and cause scarring. And the rising intraocular pressure associated with failing blebs continues to be an issue long after the glaucoma surgery has been performed. So what are the options we have at this stage? Either introduce AGM or go for a resurgery, that is a trab or tube, which again has lower success rates, or go for a bleb needling. So in Asian population, scarring is one of the main causes of filtration failure. So using an adjunctive antifibrotic agent like mitomycin C along with bleb needling can help to maintain the long-term filtration. So the purpose of our study was to evaluate the outcomes of bleb needling with high dose, that is 40 microgram injectable subconjunctival mitomycin C in failing or failed blebs. So ours was a prospective non-randomized interventional case series which included 52 eyes of 52 consecutive patients who were more than 18 years. The filtration surgery was carried out between 6 weeks and 1 year post-operative period with a failed or failing bleb with raised intraocular pressure requiring anti-glaucoma medications. We excluded any previous surgery, multiple trabeculectomies, and surgery performed more than 1 year. So we performed the procedure in an OR under topical anesthesia. The high dose mitomycin C with lidocaine is injected subconjunctivally 8 to 10 millimeter far away from the bleb area. Then the drug is swiped posteriorly, and then a bent 26 gauge needle is introduced 2 millimeter away from the bleb and advanced beneath and cutting the flap and the fibrosis. The endpoint is set as change in the appearance and the size of the bleb with adequate elevation. The elevation can be noted here. So we used a 40 microgram, that is 0.4 mg per ml, that is mixed with 0.1 ml of this solution is mixed with 0.1 ml of lignocaine. So outcome measures included intraocular pressure, number of anti-glaucoma medications, best corrected visual acuity and complications. The complete success we defined as IOP more than 5 or less than or equal to 18 without medications, or more than 20% reduction from baseline if the pre-op IOP was less than or equal to 21. Qualified success above criteria with additional AGM, and failure to meet these criteria were considered as failure. So in our study, the glaucoma duration was 2.92 years and the time interval to needling was 6.77 months. So the IOP before needling was 25.56 and the number of AGM before needling was 2.02 and the confidence interval between 18 to 46. So this is the box viscous plot showing the distribution of intraocular pressure over the visits. Here we can see the preoperative intraocular pressure, and at month 12 after the bleb needling, there was a significant reduction in the intraocular pressure. The number of anti-glaucoma medications also significantly reduced from 2.02 to 1.1 at the end of 12 months. The BCVA remained same. The success was overall around 88.3% at the end of 12 months. Coming to the discussion, the needling with mitomycin C seems to be an effective way with an overall success rate we achieved around 88.3% at 1 year. Literature has noted success between 60 to 70%. So this study by Shetty et al. Showed a 64% total success rate. So the point to be noted here is this study, slit lamp needling was done. And one more study which used high dose mitomycin C, 60 microgram they used, and the success was 84.6%. So the studies which used low dose mitomycin C reported lower success rate ranging from 57% of the eyes. So in our study, there were no corneal complication noted because we had initially separated of the mitomycin C injection from needling, which reduces the risk. So to summarize, with a simple procedure of subconjunctival injection of high dose mitomycin C along with bleb needling, it is possible to avoid a second filtration surgery. We can definitely minimize reintroduction of topical anti-glaucoma medications, but however, we need a meticulous technique and strict standard asepsis protocol to ensure minimal complication. To conclude, this inexpensive, safe, and simple intervention is a viable alternative with less surgical trauma compared to resurgeries.
Thank you. Can't we do it in OPD? Because a lot of people are doing the needling in OPD itself.
Yes, sir, we definitely can do in OPD, but then again, injecting mitomycin C and the needling, it is better and safer to do in an OR. We get more control and the
yes, it is safer, definitely. Yes. And there are cases when you can get into certain hypotony also.
Yes, sir. Yes, sir.
You don't feel that there were any of these eyes had persistent epithelial defect or any conjunctival ischemia with the high dose compared to standard dose?
No, madam. This 52 eyes which we actually did, 40 microgram we used. In fact, if you notice the other study which I showed Dr. Vanitha Pathak, 60 microgram. So this is somewhere in between and we didn't notice any corneal complications as such.
Next.
Dr. Ashok, if you could be ready.
Do we have Dr. Ashok Kumar, please? The
Dr.
next speaker is Dr. Drishti. Is Dr. Shivam here? Dr. Shivam Gupta?
This one is absent.
Yeah. Call the next speaker also on the
Dr.
other
Shivam,
side.
you can, I think, take your place here. Yes, please start.
Good morning, everyone. My topic is 1-year outcome of combined phacoemulsification and tenitomicrobe trabeculotomy in open-angle glaucoma, a randomized controlled trial. I have no financial disclosure. Minimally invasive glaucoma surgeries are the modality which are ab interno, low risk, cost-effective, highly efficacious, and minimally traumatic. These are known to bridge the therapeutic gap between the pharmacotherapy and glaucoma filtering surgeries. Tenitomicrobe trabeculotomy comes under trabecular meshwork based MIGS procedures. It cleaves the trabecular meshwork and inner wall of Schlemm's canal under direct visualization, thus reducing the trabecular aqueous humor outflow. Coming to the surgical technique, after routine phacoemulsification, the microscope is tilted 30 to 45 degrees towards the surgeon and patient's head away from the surgeon. Swan-Jacob gonio lens is used for direct visualization, and viscoelastic is used as the coupling agent. Straight hook, right-angled and left-angled microhooks are used to incise to the adequate degree required. The aim of our study was to assess the early postoperative effectiveness and safety profile of ab interno microtrabeculotomy when combined with cataract surgery in patients with open-angle glaucoma. It was a prospective, randomized, interventional, hospital-based study which included 114 patients divided into two groups, Group 1 of microhook trabeculotomy with phacoemulsification and Group 2 of phacoemulsification alone. The inclusion criteria were age 40 to 70 years, primary open-angle glaucoma, pseudo-exfoliation glaucoma, ocular hypertension with visually significant cataract and wide open angles with mean deviation of less than 12 decibels. The exclusion criteria were any prior surgery, glaucoma or cataract surgery, angle closure, traumatic or neovascular glaucoma, any corneal inflammation or retinal pathology. Coming to the success criteria, complete success was considered when the intraocular pressure was less than equal to 21 mm of mercury with more than equal to 20% reduction from the baseline without the use of anti-glaucoma medication, and qualified success when anti-glaucoma medications were used. The failure was considered when intraocular pressure was more than 21 mm of mercury or less than 5 mm of mercury on 2 consecutive visits, and the performance or if any glaucoma surgery was done or vision-threatening complications were observed. Additional criteria at intraocular pressure of less than equal to 18 mm of mercury and less than equal to 15 mm of mercury were taken. Coming to results, in both the groups, the baseline characteristics were comparable and there was significant increase in best corrected visual acuity in both the groups. In the mean intraocular pressure reduction was significantly reduced in both the groups with more significant reduction in the phaco-microlot group from preoperative 26.45 to postoperative 12.45 mm of mercury. The intraocular spikes were seen more with the phacoemulsification group, and the anti-glaucoma medication load were decreased in both the groups with more reduction in the phaco-microlot group from preoperative AGM of 0.58 to postoperative 0.16 at 12 months. The complications were comparable in both the groups with 7% hyphema seen in the phaco-microlot group but which were managed conservatively, and one patient underwent AC wash. The Kaplan-Meier survival plot was made and complete success was better seen in the phaco-microlot group in the end of 1 year. Coming to discussion, why microlot trabeculotomy? It is a cost-effective technique which is less time-consuming and has a shorter learning curve. It can be easily combined with the cataract surgery, and being an instrument which can be reused after sterilization, might be a good armamentarium for countries like India. There are studies which show similar results, but most of the studies are done outside India. The most of the studies are retrospective, observational studies. Unlike our prospective, interventional and randomized control study, there is limited literature on the efficacy of combined phacoemulsification and ab interno microtrabeculotomy, and to the best of our knowledge, this is the first prospective randomized study done on combined phacoemulsification with ab interno trabeculotomy in Indian population. To conclude, combined phacoemulsification with ab interno microtrabeculotomy is an efficacious and safe procedure in patients with mild to moderate open-angle glaucoma. It significantly reduces intraocular pressure and improves the visual acuity in early postoperative period. It may be a valuable MIGS addition to the glaucoma surgical armamentarium. Thank you.
Thank you, Dr. Drishti. And how much is the follow-up period?
So 1 year.
1 year. And
Sir,
what is the dropout in the 1 year period?
Sir, there were 3 dropouts in the phaco-microlot group, and phacoemulsification, sir, the dropouts were more with the year passing, because we were usually following up them for 6 months. After that, they usually stopped following up with us. But after 1 year, we would call them and ask them to come. The intraocular pressure was measured that time.
How much did you cut? 180 degrees?
So, sir, actually it was different according to the nasal angulation and the surgery. It was from 90 degrees till 270 degrees, and it was seen that the intraocular pressure reduction was more with the degrees of trabeculotomy done, but it was not statistically significant.
That means 90 degrees worked as much as 270 degrees, you mean?
From 90 degrees in some patients to 270 degrees in some.
And the results are?
Sir, the results showed that intraocular pressure reduction was more with higher degree of incision, but the reduction was not statistically significant.
Okay.
So, one question, what is the basis for including OHT patients in this case, in these cases?
Sir,
Case
actually,
series? What is the basis, because you are dealing with open-angle glaucoma, what is the basis of including
yes, sir.
OHT cases also?
Sir, the number of ocular hypertension glaucoma patients were only 2 in these cases, which were in that diagnostic dilemma for us. Like they had that yellowish on OCT early pre-perimetric changes, which had not developed to complete.
Since you, sorry, since you said this is cost effective, what is the difference in cost if you compare it with Bang?
Definitely, ma'am, Bang will be more cost effective, but this instrument is specifically made to target the trabecular meshwork, while Bang we just needle we use, it is not specifically meant for trabecular meshwork, and the degree of incision is also less, although Bang would be more cost effective as compared to Tenito.
Thank you.
Thank you.
Yeah, Dr. Shivam.
Very good morning to all. Hope I am audible. Thank you, Scientific Committee, for giving me the opportunity to present my free paper, Outcomes of Gonioscopy-Assisted Transluminal Trabeculotomy in Juvenile Open-Angle Glaucoma. So, juvenile ocular glaucoma is considered to be a subset of childhood glaucoma, presenting with very high IOP, and usually these patients present with very advanced glaucoma. So, both traditional filtering surgeries and GD have been seen to be working in these patients, but however, they have high failure rates, and of course, the complications are there. So, MIGs, like these are GAT, these are subconjunctiva sparing procedures. So, they have been tested in all type of glaucoma. So, there is a limited study on their efficacy in GAT and GOAG, and there was no prospective study in Indian population. So, our study aimed to the safety and efficacy of GAT in patients with juvenile open-angle glaucoma, and the study design was prospective study, and the follow-up was for the 6 months. We included the patient with maximal medical therapy, with or those who could not tolerate the medications, patient who showed progression, target IOP was not achieved, and we divided our study population into 2 groups, the moderate ones, less than 12 dB, and more than 12 decibel, the severe ones. We excluded the patients with ocular trauma, ocular surgery, any corneal abnormality, and patients who were not anticoagulant therapy. So these are the steps of our surgery. As a routine GAT, we did use a 5-clonine suture. We blunted the tip. We did a 2 mm nasal goniotomy, and they introduced the suture in it. After 10 to 30 strokes, we retried it from the other end, and thus completing a 360-degree trabeculotomy. Outcome measures were intraocular pressure, anti-glaucoma medications, surgical success, complication, and best corrected visual acuity. So sample size was calculated 30 by the power 80%, and achieving expecting a IOP reduction of 40%. The success criteria was determined on 2 levels. The first level was 20% reduction and less than 21 mmHg without anti-glaucoma medication. Criteria 2 being 18 mmHg with 25% reduction without anti-glaucoma medication. Qualified success was this with a single AGM. So we had 26 patients, 11 in the moderate group and 19 in the advanced group. So if you see there was significant reduction in intraocular pressure in AGM from 23.43 mmHg to 40 mmHg, and 2.93 anti-glaucoma medications to 0.8. And if we look at the IOP reduction percentage, it reduced at 38.6% at the week 1 and up till 30.9% at the end of 6 months. And if we look at patients who are on anti-glaucoma free medications, like a medication-free group, they were 16, they were totally medication-free at the end of 6 months, and less than 1 medication was like 5 patients, like 16.7 patients required. Total 70% patients in short were required for less than 1 medication. If we compared the 2 groups, the moderate and the advanced group, the outcomes were almost same. There was no significant difference between the 2 groups, and they had a good IOP reduction in both the groups. If we look at the success criteria, both the criteria 1 and criteria 2 had a good, at the end of 6 months, it was around 73.7% by using both the criteria 1, criteria 2 in either group 1 as well as group 2. So if you look at the complications, we had 1 or 2 patients with IOP spike. Microhyphema was seen in 6 patients, which resolved at the end of 1 week. Macrohyphema was seen in 1 patient, which required anterior chamber wash. So if we compare to our study with the previous done studies, we have some patients with, we had some studies showing GAT having 65.6% complete success, And others, like with Q et al. Showed 58.6% reductions, and a bigger sample size of prospective study of 12 months showed 74.3. Ours being Indian population, a complete success coming to 70.7%. Coming on to the SWOT analysis of our study, the strength of our study was there was no previous studies in Indian eyes, comparison between the moderate and advanced GOAG, and weakness being short duration follow-up, small sample size. The opportunities can be, this can be an alternative to the traditional surgeries, and threat can be, yes, we have to think about the complications. So what was known before was surgical treatment of GOAG is particularly challenging, especially with traditional surgery, which has a poor success rate. GAT is effective in patients with juvenile glaucoma. There are few studies available.
Dr. Mayank.
What our study adds is that GAT is effective and safe in GOAG patients in Indian populations, and GAT is effective in both moderate and advanced GOAG with little minimal complications. Thank you.
There's
Thank you, Dr.
paucity of
After Dr. Mayank, Dr. Kavya has to be ready, right? And then Dr. Jaya, Dr. Shivani, Dr. Anuja, Dr. Tanya.
The slides are not moving actually.
AV, please. The slides are not moving. They're there, right?
Audio visual, if this is not moving, can you give the next?
next speaker.
Dr.
you-
Kavya,
She's
can
there.
you see if your
You can
slides are-
start.
If it is coming.
Coming, you can start. They have to. Can you?
Who's the audio visual? Yeah. Kiska
Okay.
hai?
It's not coming, ma'am.
We are starting with Dr. Kavya's presentation. Judges, please note.
Please set this up correctly. Kavya's time can't be up without starting.
Slide? Is it Kavya?
हाँ,
Is
Kavya
it
slide है, but
Mayank, your slide is not opening?
Shivam.
So should I go ahead with Kavya slide? Please, Kavya, go ahead.
Even her PPT has gone off now.
Can you please put it on slideshow?
In the meantime, please sort it out.
Okay, start.
Good morning all. First of all, thank you the committee for giving the opportunity. I am going to discuss about the evaluation of microvascular changes and optic nerve head perfusion following trabeculectomy and optical coherence tomography angiography study. Glaucoma is a multifactorial optic neuropathy among which vascular theory makes hypothesize that vascular dysregulation can lead to derangement of optic nerve head perfusion and peripapillary retinal microvascular circulation. The changes at the microvascular level can be evaluated using OCT angiography. Optic nerve head angiography is done and the scan is taken with the area of 4.5 into 4.5 millimeter, and the software automatically fixes an ellipse to the optic disc margin with which we measure flux index and perivascular vessel density. Flux index or flow index is the number of blood vessels passing through the retinal vessel per cross-sectional area per unit time, and perivascular vessel density is described as the percentage area occupied by vessels in the area of interest. There are limited studies regarding how trabeculectomy changes the optic nerve perfusion and peripapillary microvasculature. So we proceeded with the aim of the study to determine the effect of trabeculectomy on peripapillary vessel density and optic nerve head perfusion in primary glaucoma patients using OCT angiography. So we included the patients in the range of 40 to 70 years with primary open angle glaucoma and primary angle closure glaucoma. And we excluded the patients who underwent prior cataract surgery with high refractive errors and patients with, who had undergone retinal surgeries and with media opacities in visual axis, and who are unable to maintain fixation during the procedures, and best corrected visual acuity less than 6/18, and signal strength of OCT angiography less than 10, and patient with acute attack of angle closure, and patient with history of retinal pathology, and monocular patients, and patients on systemic medications which affect the vasculature. So we calculated the sample size of 6 by taking reference with 12% precision and 95% confidence interval. The study is a prospective observational study, and we included 76 subjects who underwent trabeculectomy, and we have done OCT angio at first week preoperatively, and on first, third, and 6-month postoperative follow-ups, and we measured the changes in PVD, perfusion index, and flux index. Coming to the results, peripapillary vessel density showed an significant improvement in the significant improvement at the end of the 6-month follow-up. As we can see in this image, both of the group, both pre-OAG and PACG group shows the increment in the PVD. Here we measured the sectoral PVD changes, superior, nasal, inferior, and temporal PVD measurement also showing the same incremental effect. Then there was significant increase in the perfusion index in both the groups. Here we can see the structure RPC plot showing the increment in the peripapillary capillaries. So coming to the discussion, according to the vascular theory, the vascular dysregulation is responsible for the derangement of the perfusion of the optic nerve head and peripapillary retina. So OCT has the ability to demonstrate and to quantify the retinal and optic blood supply. So Jung et al. In their study demonstrated that there is reversal of microvasculature and structural parameters post-trabeculectomy in 25 patients. And Saho et al. Also demonstrated decreased optic nerve head perfusion due to high IOP, which can be reversed by reduction of IOP by trabeculectomy. Leo et al. Demonstrated that there was an improvement in retinal perfusion parameters after IOP lowering surgeries. We had few limitations like small sample size, and the patients included were more elderly, and OCT angio does not differentiate large vessels from small capillaries. And we came to a conclusion that OCT angiography demonstrated a significant improvement in peripapillary vessel density and optic nerve head perfusion after trabeculectomy in both POAG and PACG patients. And thus we concluded that OCT angiography is a promising technique that has potential to further enhance our understanding of ocular perfusion and may yield valuable insights into prognosis after surgery. Thank you.
Thank you, Dr. Kavya. Dr. Mayank?
You can upload my PPT there. It's not showing there.
Dr. Jaya, can you please be ready? Dr. Jaya Kaushik?
It has
Dr. Shivani?
So, good morning everyone. As we all know that the management of neovascular glaucoma is challenging because of elevated IOP, retinal ischemia, and multiple systemic risk factors. Also, the conventional filtering surgery is bound to fail. So consequently, we have tried to, we all know that glaucoma drainage device offer a safer and effective alternative to management, persistent, mainly due to Ahmed glaucoma valves. So these are the abbreviations I've used in my presentation. We all know that ischemic central retinal vein occlusion, PDR, and OIS are the most common causes of neovascular glaucoma. Now the management strategy involves dealing with multiple risk factors, either sequentially or concurrently, which includes treatment of IOP, managing systemic conditions, and treatment of retinal ischemia and inflammation. While talking about our learning from literature, what we know that in routine clinical practice, glaucoma drainage devices are reserved for eyes with persistent new vessel or high risk of trabeculectomy failure, or wherein the filtering surgeries are not feasible. So in our study, we tried to evaluate the long-term surgical outcome of Ahmed glaucoma valve implantation in patients with neovascular glaucoma secondary to various etiologies. Ours was a retrospective studies wherein we included 27 eyes or 27 patients diagnosed with NVG. Our groups were comparable. The patients in other category included patients post-occlusive vasculitis and retinopathy of prematurity. So we included all the patients who have undergone AGV implantation secondary to neovascular glaucoma with a minimum 3-month post-operative follow-up. The eyes with no light perception vision at presentation were excluded, and the eyes with less than 3 months follow-up were also excluded. While the primary outcome measure was AGV success, which was defined as IOP between 6 to 21 millimeter of mercury without a topical anti-glaucoma medication, the failure was defined as one of the following, where the IOP was more than 21 despite maximum tolerated medication. There was need for additional surgery to control IOP, or there was loss of light perception due to surgical complication. While talking about hypertensive phase, it was characterized by IOP more than 21 despite initial post-op reduction within first 3-4 months after surgery with accompanying cystic and tense bleb. A resolution was defined as IOP less than 21 with a reduction in AGM, and to proactively prevent hypertensive phase, we have started patient on aqueous suppression. So the statistical analysis was performed using SPSS version 26.0, and p-value less than 0.05 was considered statistically significant. So in our cohort, which predominantly had male with a median age group of 61 years, there was maintenance of visual acuity in the post-op period with a reduction in IOP, which was maintained over all the follow-up, and a reduced dependence of anti-glaucoma medication. While talking about comparison with the group, as we see here, there is no statistically significant difference, but patient in OIS category seem to benefit more with AG1 implantation in terms of gain in visual acuity as well as reduction in intraocular pressure. The median and mean survival times were better in the OIS and CRVA group and less in PDR group because of the progressive nature of disease and a higher IOP at presentation in the PDR group. So complications, there were 2 complications, tube exposure noted in CRVA and PDR group, and 2 patients underwent TSCPC in PDR and OIS group for uncontrolled IOP. While comparing with literature, our study showed a better outcome in OIS and CRVO group as compared to PDR group because PDR group patient had persistent neovascularization as well as worse visual acuity at presentation. So the strength of our study has that we have directly evaluated and compared the outcome of AGV among the 3 common etiologies of neovascular glaucoma. The limitation includes the retrospective nature of study with the irregular follow-up of patients due to COVID-19 pandemic and a smaller sample size. So we can conclude that AGV implantation can be considered as an effective surgical option to reduce IOP and number of anti-glaucoma medication for neovascular glaucoma of varying etiologies. Thank you.
Yeah, thank you, Dr. Mayank. Is that Dr. Shivani? You're ready with your slides? And Dr. Anuja, you're next. Is Dr. Tanya available?
Dr. Jeb, you can start. Dr. Jaya can start. Slides, please. Yeah, please carry on.
No,
Your slides are on.
Dr. Jaya is not there.
And what is your name, please? Who is presenting?
This is Dr. Shivani. AV, please put the slides of Dr. Shivani.
1988.
Yeah,
thank you.
What is your name, please?
Shivani.
Shivani, okay.
So, good morning everyone. Today I am presenting about the long-term outcomes of GDDs following failed initial combined trabeculotomy and trabeculectomies in refractory primary congenital glaucomas. So, as you all know, in India our first choice of treatment for primary congenital glaucoma is combined trabeculotomy and trabeculectomy. Like any other glaucoma procedures, even CCT had a success failure due to the subconjunctival fibrosis or scarring which can lead to bleb failures. So mitomycin C might have enhanced the outcomes of these things, but due to these complications of the usage of mitomycin C, we are not using mitomycin C in a much role. So GDD is a choice for refractory primary congenital glaucomas. So we already made a study comparing both non-walled and walled implants in pediatric glaucoma eyes in Indian eyes, where showing complete success is more in non-walled implants compared to walled implants, whereas qualified success is greater than 80% at 2 years. So to continuation to that study, we have evaluated the long-term outcomes of glaucoma drainage implants in primary congenital glaucoma eyes with prior failed primary combined trabeculotomy with trabeculectomies. So we have included all the primary congenital glaucoma eyes who have underwent GDDs, who have a failed CCT with greater follow-up of 5 years. So we have excluded the eyes which have less than 5 years follow-up and who had secondary developmental or acquired glaucomas and who had underwent primary GDDs. This is a retrospective study which included 60 eyes of 41 children between December 2009 and November 2019.
We have defined success as intraocular pressure between 5 and 21 millimeters of mercury without AGMs as complete and with AGMs as qualified. Failure was defined as intraocular pressure greater than 21 millimeters of mercury with AGMs, where repeat glaucoma surgeries were required, and complication needing implant removals and loss of light perceptions. So out of 60 eyes, 38 eyes underwent AGV, whereas 22 eyes underwent RT implants. So comparing the baseline demographics and clinical characteristics of the cohort between RD and AGV at different intervals of time. So before CTT, median usage of AGMs was greater in RD cohort, but after CTT and before implants, AGM usage is more in AGVs. But after undergoing glaucoma drainage devices, AGM need was much less in RD implants. So in both the groups, the median follow-up is 7.5 years. Coming to the complete success probability of walled and non-walled implants, the complete success of AGV implant is much less at 1 year, that is 18%, whereas RD implant it is 77%. Qualified success at 1 year is 92% at 1 year, and for RD implant it is 82%, whereas at 5 years it is 71% for AGV, whereas for RD it is 59%. So even after implantation, 12 eyes in both the groups required glaucoma resurgeries, whereas 29 eyes required non-glaucoma surgeries, especially like lens aspirations and penetrating keratoplasties. Coming to the complications, we have 8 eyes who had complications where 6 eyes required interventions. So choroidal detachment was seen in 3 eyes, where in 1 eye tube religation was done. So instead of doing tube religation, even hypotony persisted, leading to retinal detachment and phthisis. Conjunctival erosions and endophthalmitis was seen in 1 eye. So implant was removed and endophthalmitis was treated. So after 3 months, again TSCPC was done. In one of the eyes, there is a posterior displacement of the GDD, so implant removal was done. So after 4 months, again RD implant was done. Tube corneal touch was seen in 3 eyes. Higher IOP at presentations and longer duration from CTT to GDD were risk factors for failure of complete success, whereas older age at CTT was associated with failure of qualified success. So GDD demonstrated moderate to long-term efficacy in PCG post-failed CTT. Qualified success ranged between 59 to 71% in RD and AGV at 5 to 10 years. 10% eyes needed intervention to manage long-term complications. Higher IOP at presentations and older age at CCT were significant risk factors for failure. Thank you.
Right, thank you, Dr. Shivani. We have Dr. Anuja next. Dr. Tanya, can you please be ready with your slides?
Very good morning to all. Today I am going to present my work on long-term outcomes of needle-assisted circumferential goniotomy in primary congenital glaucoma. As we all know, primary congenital glaucoma accounts for 0.01 to 0.04% of wild-blind blindness and is characterized by maldevelopment of trabecular meshwork. The definitive management is surgical, which can be angle surgery or filtering surgery. The advantages of goniotomy include that it's a minimally invasive procedure with a conjunctival sparing technique, and it avoids a long-term bleb-related complications. It's also a cost-effective procedure. So traditionally described angle surgery opens about 1/3 of the angle in a single step, and hence there might be a need of multiple procedure to open the entire angle. So currently we are considering 360-degree procedure, and hence we performed a prospective analysis on surgical outcome of 360-degree goniotomy in primary congenital glaucoma patients. So infants who presented to congenital glaucoma clinic were screened, and we included 52 eyes of 31 patients who were of less than 2 years and had good corneal clarity. We excluded those who had dense corneal hairs, who had secondary childhood glaucomas, and parents who were not willing to give consent and age more than 2 years were excluded. So after doing an evaluation under anesthesia, we performed a nasal goniotomy by using a bent 24-gauge needle, and we inserted that needle from the temporal limbus and performed the nasal goniotomy after visualizing the angle using a Schwann-Jacob lens. The high-iris tissue insertion was incised and iris fallback was noted. Similarly, temporal goniotomy was performed by inserting this bent needle from the nasal side of the limbus, And similarly, we did the procedure of goniotomy and followed by irrigation and aspiration to remove all the viscoelastic substance, and the anterior chamber was formed and the wound was hydrated and sutured. So this is the pre-op high-res tissue insertion which was noted, and post-operatively iris fallback with an opening of cleft after goniotomy was noted. The patient was followed up immediately on day 1, 1 week, 3 months, 6, 9 and 12 monthly, and at each follow-up we determined IOP and total number of anti-glaucoma medications. Absolute success was considered when the IOP was less than 18 mm mercury with no anti-glaucoma medication, and qualified when the IOP was less than 18 on less than 2 anti-glaucoma medication, and failure when the IOP was more than 18 on 2 topical anti-glaucoma medication. So this is the mean pre-op intraocular pressure, which was 23.28 plus minus 5.9 mm mercury, which was reduced to 12.5 plus minus 5.09 at 12 months. And which was a statistically significant reduction, and also the mean number of anti-glaucoma medication reduced from 2.48 plus minus 1.03 to 1.35 at 12 months follow. These are the baseline characteristics. The mean age was 1.14 plus minus 1.04 years, and the IOP and the anti-glaucoma medication had already been discussed. The mean cup disc ratio was 0.6 plus minus 0.2. Coming to success rate, complete success was seen in 40% and qualified success was seen in 48%. So at 12 months, around 9.61 eyes required additional surgery, which was trabeculectomy, and the complication which was seen was hyphema, which was managed conservatively in 19.23% of eyes. So why 360-degree goniotomy is needed? Basically, aqueous outflow channels are not symmetrical, and the entire angle is treated at one single step. There is no need of multiple anesthesia to the child, and there is a reduction in the parental stress. It's also a cost-effective procedure. A study conducted by Maria Lim et al. Had shown 360-degree trabeculectomy with illuminated microcatheter to have success of 85.71% as compared to partial trabeculectomy in terms of intraocular pressure and AGM at 1 year. Also, trabeculectomy or combined trabeculectomy with trabeculotomy will lead to manipulation of conjunctiva and use of antimetabolites and will have bleb-related complications. So there are a few studies by Kaushik et al. Who have compared goniotomy for initial and redo surgery, and at 1 year they had found a success rate of 79.7% in a primary surgery and 68.4% in a redo surgery. Mendicino et al. Have conducted study who have evaluated surgical and visual outcome in primary congenital glaucoma, trabeculectomy 360-degree versus goniotomy, and they had found intraocular pressure reduction of in 92% of eye in 360-degree trabeculotomy versus 58% in goniotomy. Thornset et al. They have evaluated circumferential trabeculotomy in primary congenital glaucoma, and complete
Dr.
success
Anuja,
was
your time is
85.
up. Can you conclude your presentation, please?
So to conclude, patients with pediatric glaucoma often requires multiple surgeries to control intraocular pressure, and this study basically highlights the benefit of circumferential goniotomy, where entire angle is treated in one single step with significant reduction in intraocular pressure and anti-glaucoma medication. Thank you.
Thank you. Dr. Tanya, please.
Good morning to one and all. Today I am presenting my thesis topic, a comparative trial between trabeculectomy versus phacoemulsification with or without angle surgery for glaucoma and nanophthalmos. So as we all know that nanophthalmos is a condition in which the axial length of eye is less than 20.5 mm without any ocular malformation. Such eyes are predisposed to angle closure glaucoma. They also have a shallow anterior chamber, a narrow angle with a high lens to eye volume ratio. Surgeries in these eyes are associated with extremely high complications.
Dr. Ria, please be ready.
The rationale of the study is that there is very limited understanding for the standard
Dr. Avik
procedure
Kumar
for
Roy.
intraocular pressure control in these eyes, as the epidemiological data is very less due to the rarity of the disease. Also, as these surgeries are associated with high intraoperative and postoperative complications. So, we thought of doing a study to compare the safety, durability, efficacy of different surgeries to control pressure in these eyes. So from the studies from the past, we have seen that there was no evidence existing which says which surgery is better for controlling pressure in these eyes. There was no biometric cutoff available for deciding the procedure of choice, and there was no comparison done between trabeculectomy or phacoemulsification with or without angle surgery for management of glaucoma in these eyes. The primary objective was to find out the assessment, was to assess the profile and severity of glaucoma in these patients, and also to find out the efficacy and safety of surgery in lowering IOP in these eyes. So we did an ambispective study at our center. We recruited patients, and the absolute success was defined with IOP less than 18 mm Hg without the use of glaucoma medication, and qualified when we use medications. Statistical analysis was done. We recruited 41 eyes of 34 patients, 18 eyes in the trabeculectomy group, and 23 eyes in the phacoemulsification with or without angle surgery group. These were the preoperative data which was comparable in both the groups. We saw that there was a reduction of IOP in both the groups, but the IOP reduction in the phacoemulsification group was 51% at least 1 year after surgery, with a mean IOP of 15.4 millimeters of mercury. The survival of the surgery, that is phacoemulsification, was much higher when compared to trabeculectomy. Also, the vision was improved in the phacoemulsification group, and we saw that at least 13 eyes gained 2 or more lines of logmar vision, whereas in the trap group, the vision dropped by 2 or more lines in majority of the patients. The number of medications to control IOP was significantly reduced in both the groups. However, we saw that the eyes which underwent trap were using 1.5 times more number of medications. The absolute success was achieved only by the phacoemulsification plus minus angle surgery patients. None of the trap patients would achieve absolute success. And also, the number of re-interventions was significantly higher in the trabeculectomy group. We also found out that eyes with a chorioretinal thickness greater than 1.7 mm was associated with the complications 1.5 times more than the normal CRT thickness. So we conclude that the phacoemulsification with or without angle surgery is more effective and safer means for managing IOP of eyes in these patients. Long-term studies are warranted to look for the results. Sample size was small owing to the rarity of disease, and also as it was a multi-surgeon approach and cases were recruited from past, so these becomes the limitations of my studies. Thank you.
Thank you. Dr. Ria is not available, I think. We have Dr. Avik?
Yes.
Yeah, please.
Shall I start?
Yes, please.
So thank you for the invitation. So I guess my topic was the novel umbilical cord allograft in preventing the hypertensive phase in the AGVs. So in the trap phase, we have the options of to restart the AGMs, or to plan for repeat trap in different quadrant, or to plan for a tube, and to plan for a TSCVC if everything fails. So we know the indications for the GDDs, like different difficult glaucomas, like the neovascular glaucomas or failure of traps and different other difficult glaucomas. And the GDDs have evolved for a long history from 1906 to the recent inventions like the Amit clear path and the Paul implants. So hypotony is one of the difficult challenge in the post-implant surgeries, and different implants like the valved and non-valved implants, they have their different clinical courses as far as hypotony is concerned. The challenge of the hypertensive phase comes after the initial hypertensive phase is over. The hypertensive phase is characterized by a huge cyst, thick bleb with IOPs of more than 21 in the first 3 months after surgery. And it is like a kind of analogous to the tenon cyst of trabeculectomy. It's a thick cystic bleb, and the incidences can be as high as 60 to 80% after the implant surgeries. The different risk factors will be there. And the problem is that we are again back to square one, meaning that we need to again restart the medications. And significant part of these patients can also be converted into a failure. Just to discuss one short case report of a 10-year-old girl with a Sturge-Weber syndrome. She had a refractory hypertensive phase following the 2 implants. The 2 implants were placed in the eyes with supratemporal and infratemporal quadrant, but the IOPs didn't come under control. So planning for a TSCVC. So the management of hypertensive phase includes a lot of options like the intra Tennant's capsule resections to the amniotic membrane or post-op steroids, digital massage, but none has been like proven conclusively except the post-op, the prophylactic medications. So post-op prophylactic AGMs acts as a medical ligature to prevent the initial flow of the inflammatory aqueous. It is proven to be useful in preventing the hypertensive phase as well as to reduce the height of the hypertensive phase. So the AGV slicing is also one good interventions to cut the valve into a non-valve implant, and the in vitro studies are there, but in vivo studies are not yet been done. So coming to our discussion today, the novel umbilical cord allograft. In the studies, initial studies have done by Dr. Aparna Rao, and she had shown that around 34 eyes where 6 months follow-up, there's good initial outcome of good success rates in reducing the hypertensive phase. So it's a very simple procedure. Umbilical cord allograft is fashioned into a small piece around 3 to 4 mm in the dimensions, and it is to be just slided over the valve area beyond the scleral patch graft. So it will stay there, and followed by simply closing the conjunctiva with the aetovehicle suture. So simple technique by placing the umbilical cord allograft, and this will be the blade height will be less, the IOPs will be low as what we expect. So coming to our results at a 1 year follow-up data, so we had 44 cases compared to 38 control eyes, and the final IOP and the number of medications were lesser in comparison to control eyes, but the number of eyes who need repeat surgeries as well as the number of eyes with high hypertensive phase were not improved by the use of this umbilical cord allograft. So the Kaplan-Meier survival curve also showed that the eyes with this particular allograft didn't score better than the eyes without that allograft. So ultimately, the results are not that impressive one, but this is a promising technique, and we believe that if we tweak the technique to some extent, we can have better results as time goes by. So to conclude, the road after implant surgery is not always smooth. There will be ups and downs, and best of luck driving. Thank you.
Thank you, Dr. Avek. Sir, any comments on that?
Is it commercially available?
Yes, it is commercially available.
Okay.
Thank you.
And how many can you harvest?
So one piece of this particular allograft is available, and it is priced around 5,000. So you can have make 4 pieces.
Cut it, okay.
Yeah, cut it.
You can use it in 4 patients.
Yeah, 4 patients.
And how do you store it?
It is stored in the MK medium.
Thank you.
Thank you.
So
Thank
we
you, Dr. Rai.
conclude
Thank
this
you very
session.
much.
Yeah.
And my all thanks for my co-colleagues and the co-panelists. And can I have a photograph?
Can we have all the speakers on the stage, please?